DNA, in particular in twin and multiple pregnancies. So just really go back to basics. So what tests do we have screening for chromosomal anomalies, particularly obviously the common trisomies in twin or particularly in twins, and how different they are in terms of the performance, and also whether they give us, what gestational age window we offer them, and whether they give us a pregnancy specific risk or a fetus level specific risk. So obviously cell-free DNA, we have it for a number of years. It's offered from 10 weeks. It can be offered at any stage in pregnancy. So it's one of the questions from the delegates. We're saying, well, I see most of the twins, they come to me after 20 weeks because they don't really come early in pregnancy. Can we offer an IVT or cell-free DNA? And the answer is yes, you can offer it until the end of the pregnancy. Performance, very high. We have a lot of data, and we published a recent meta-analysis with Francesco summarizing the latest evidence published literally a few months ago in the Wire Journal. And the performance, particularly for trisomy 21, is almost close to 100% for less than 0.1% false positive rate. Compared to the combined test is only offered really in gestation age window between 11 weeks and 13 weeks plus 6 days. You can't offer it before, you can't offer it after. And the detection rate, I would say, will be between 85 to maybe just under or 88% for a 5% false positive rate. It's also true that there are some countries where they don't really have the biochemistry component of the combined test, and therefore they just maternal age and nuchal translucency, the same gestation age window, 11 weeks to 13 weeks plus 6 days, detection rate about 80% for 5% false positive rate. And I put the quadruple test, but I really strongly recommend not to offer it in twin pregnancies. It can be offered in the second trimester, so that's mainly in the UK for women who miss the first trimester scan, or they are late booker, so between 15 and 22 weeks. But the detection rate is so low, it's 50% for 5% false positive rate. So it's like tossing a coin, really. So definitely for me, I would not recommend offering the quadruple test. The other thing that we need to also understand in managing, as clinicians, managing these pregnancies, whether the test give you individual fetal risk assessment. And for cell-free DNA or NIPT and the quadruple test, it doesn't. It gives you a pregnancy risk. It doesn't tell you per fetus which twin is affected, and therefore it's up to you as a clinician to figure out which one is affected or whether both twins are affected. This meta-analysis combined or pulled the data from the literature and reported that the combined test performance actually similar, whether it's dichronic or monochronic twin pregnancies, was about 85% for a 5% false positive rate. In singleton, cell-free DNA or NIPT is the most accurate screening test. The performance is very high with a very low detection rate. What about in twins? Well, certainly at the early stages of cell-free DNA, we said, well, monochronic twins, the same as singleton. And it'll be interesting to hear sort of the views of the speakers, whether that's reasonable assumption. And we heard earlier that obviously there are rare situations where you have heterokaryotype pregnancies. So can we have, is this assumption is valid or not? And we also heard earlier that the fact that we should take the lower limit of the cell-free DNA because we need to get around each twin contribution to the cell-free DNA. So despite the fact that total fetal fraction in a twin pregnancy is about 1.6 times higher than in singleton, the average per fetal, so the average fetal fraction per twin is actually lower. So it's in twin about 8% compared to 11% in singleton. And I really like this graph because it's very sort of give us in the message in a very clear way. So we know that the risk factors for failed NIPT, of course, obesity, IVF pregnancies, twin pregnancies. But on the right-hand side, if you see, this is on the y-axis, the failure rate. And in the x-axis, the maternal BMI. And the dotted line, the dotted curve, is the twins, and the solid is a singleton, and the gray is IVF pregnancies, and the black is non-IVF pregnancies. And this is data for a woman who's 35 years old, Caucasian, and the fetus is crown round length of about 55 millimeters. And if you, for example, draw a line here, if a woman who's obese, BMI of 40 kg per meter square, if you put it up, the failure rate, if you have a twin pregnancy from an IVF conception, is actually close to 50%. So, and therefore, we need to take that into account while we counsel our parents. I don't think it's necessarily we're not going to offer it, but we really need to warn the patient of the risk of failure result. And therefore, I think if it depends where you work, you need to have a backup plan if the result of the cell-free DNA failed. Are you going to be able to offer the combined test? Would you be able to offer an invasive testing? And therefore, the data is consistent that the failure rate is higher in twins compared to singleton, but also the repeat sampling. In singleton, you get the result in about maybe now 75%, while in twins is less, it's about 50%. Yeah, so failure rate twins about 9% compared to 3% in singleton. So how does the cell-free DNA, the performance compares in twins versus singleton? Well, if you have a fixed false positive rate of less than 1%, you see that the performance for the common trisomies in singleton, while actually in twins. So it is true, it's slightly less in twins compared to singleton. But for trisomy 21, the performance is excellent. It's almost as close as in singleton, but the data suggests that it's less so for trisomy 18 and trisomy 13. So about 80% versus about 96% in singleton, 92% for trisomy 13 and 18. What's the most recent evidence? And I said we published this meta-analysis with Francesco and a number of collaborators very recently, literally a few months ago in a Y journal. And this data, very large number of twin pregnancies, the failure rate was about 1.2%. And you see the detection rate almost 99% for Down syndrome, for screen positive rate of, again, almost specificity about 100%, trisomy 18, detection rate 95%, specificity 82%. For trisomy 13, 85%. Specificity is difficult we could not really pool the data to calculate a reliable estimate for the specificity for trisomy 18. We did something which is, maybe I think you take the results with a pinch of salt, is about the sex chromosome aneuploidy and microdeletion and microduplication for twin pregnancies. But I really liked Mark's presentation when you shared some of this in data from your work, from your laboratory, about sex chromosomes or microdeletion, microduplication, because the truth is that parents do ask for it. You know, parents have access to the internet, and certainly the companies do offer testing for additional conditions. And we have limited data, limited evidence on the performance in twin pregnancies. So the data suggests, and small numbers in the literature, but suggests that the detection is 86% for 0.2% false positive rate. Obviously, there is the confident 95% confidence interval, but microdeletion, microduplication, what is reported suggests is very high. But as I put two question marks because the numbers are really, really limited. It's difficult to interpret that with a high level of confidence. And the fact that we have a large number of twin pregnancies allowed us to do some sensitivity analysis or some subgroup analysis and to test whether the performance of the cell-free DNA in twin pregnancies differ according to the chorionicity. And remember, I mentioned earlier, monochorionic twins are usually monozygotic, and therefore you can argue that you treat them as singleton, and you see the performance is excellent in monochorionic twins. Small number in trisomy 13 was only one study. But in dichorionic twin pregnancy, again, the performance seems to be very promising in terms of the detection rate for the common trisomies, 98%, 92%, 89%, nearly 90%. I'm just going to show you a few cases, which is from sort of the clinical practice to give some key messages. So this lady who's 39 years old with IVF pregnancy, DCGA, she had a routine scan in the UK. We're still offering the combined test as a first line. So at 12 weeks, one twin, nuchal of 1.5, and the second twin, nuchal of 2.1. Normal on the scan, normal nuchal. And this is the biochemistry. And you see that the calculated risk you see for twin, both of them for twin 1 or twin 2, the risk is low for trisomy 21 or trisomy 13 and 18. So with a cutoff of 1 in 150, that will not really necessarily qualify for offering invasive testing or considering further testing or further risk for trisomy, common trisomies. She goes and have a private NIPT, and the result is high risk for trisomy 21. So she come back and say, well, I've got this result. At that time, gestation age is 14 weeks, and therefore I do ultrasound scan, detailed ultrasound scan. Twin 1 is a female with normal ultrasound scan, while twin 2 is a male, and the only thing with the tricuspid regurgitation. So we have counseling, and you do CBS for both babies and have an echo on the same day. The echo confirms that the heart is structurally normal, confirmed that the twin 2 has moderate tricuspid regurgitation. So we do the 2 CVSs, and the result, twin 1, normal PCR, on twin 2, the one that had the tricuspid regurgitation, come back as trisomy 21. The array in twin 1 confirmed is a normal female, and a twin 2 was failed. So in the UK, we do have the option of delaying the selective termination if the parents wish to the 3rd trimester in order to reduce the risk of preterm birth to the healthy twin. And we heard earlier from Lisa about the results of selective termination. So anyway, so we carry on with the pregnancy, and it's 17 weeks when you start maybe seeing very, very subtle features. So twin 2, left-sided mild pleural effusion, and you can see here very, very subtle. I mean, easy to be missed. It's only because we're already looking for features of trisomy 21 in the 2nd twin. The echo again confirms that the heart is normal, and the only thing in twin 2 is the ARSA, or the apparent right subclavian artery, and the tricuspid regurgitation resolved, as you would expect. Only really until 27 weeks, when you started seeing other features like short femur in the 2nd twin or polyhydramnias. Again, there was no double bubble, there's no signs of duodenal atresia. And of course, in this case, we monitor the cervix to see whether the risk of preterm birth, because if the cervix is getting short or this polyhydramnias is getting worse, that might be indication to do a selective termination earlier to avoid the risk of preterm birth. And delivering twin 2 alive, because the parents wanted to have selective termination. So at 31 weeks plus 3 days, she have the selective termination, confirmed trisomy 21 on the amniotic fluid sample, and a couple of weeks later, she goes into labor, have emergency intersection, and have a live birth female baby. And just maybe I'm going to share with you this case quickly, just to really show you how difficult it is, can be, and challenging counseling and managing this pregnancy. So it's 42 years old, first pregnancy, spontaneous DCGA twins, and she goes and have an NIPT at 10 weeks and come back as an increased risk of trisomy 21. So we do the ultrasound scan, and twin 1 completely normal, no markers whatsoever, nuchal of 2.1. And twin 2, the nuchal of 2.7, there is tricuspid regurgitation, there is suspected FASD, and therefore we suspect that twin 2 is the one that's affected by trisomy 21, counsel the parents, they go for double CVS. And the PCR, surprisingly, it'll be interesting to hear people's views, come back as both twins are affected by trisomy 21, and in fact, it's a monozygotic twin pregnancy. The monozygotic dichorionic twin pregnancies, and both of them are the same gender. So the parents come back, we counsel them about these results, we scan again, and again, twin 1 have no markers whatsoever. Nuchal is completely normal, the heart is normal, ductus is normal, tricuspid regurgitation is normal. And these parents are very, very keen to have a healthy child. She's 42 years old. So would you act on the result? Would you offer termination of the whole pregnancy? Would you do selective termination of the 2nd twin? What's the chance of contamination, or that you sample the same twin twice, for example? We did actually went to the government in the UK whether we should be testing or offering NIPT early in pregnancy. So whether actually at the moment in the UK, you have the combined test at 12 weeks, and then if the risk is high, the patient get counseled, you do the invasive testing, and if the risk is high, this is when you offer the parents option of selective termination. And if you look at the chronological, that means that you might end up by offering selective termination in the second trimester, which obviously have higher risk of preterm birth or miscarriage. And therefore, we discussed with the government whether we should be offering NIPT to twin pregnancies early rather than waiting for the combined test first. So offering at 10 to 11 weeks NIPT and ultrasound scan. And that means if there is high risk result, that you're able to offer invasive testing at 11 to 12 weeks. And then if there is a confirmed high risk result, that you're able to offer selective termination in the first trimester, which is obviously associated with lower risk of miscarriage or preterm birth. And that was really triggered by this case. So this woman who had increased risk of trisomy 21 using the combined test. By the time she has counseling and have an NIPT first, because there was no markers on the ultrasound scan. And then the NIPT come back as a high risk for trisomy 21. She's already, by that time, 14 weeks. She have double amniocentesis and she had recurrent bleeding. And she is still considering the option. And then she have rupture of membrane at 24 weeks and deliver and have the 2 babies born alive, including the baby with trisomy 21. So that was really the trigger of having this conversation with the government, whether we should be offering NIPT early to twin pregnancies. For Vanishing Twin, I think we already had a very nice talk and the recent data from Francesco and Antonio. But certainly, really, the key message is that you have higher false positive rate. Interestingly, the literature suggests that there is no discordant negative results. And he showed you this result already. So for trisomy 21, the screen positive rate was 2%, trisomy 18, 0.9%, and trisomy 13, 0.4%. And very importantly and very relevant to the discussion and counseling the parents is a positive predictive value. For trisomy 21, with 20%, so 1 in 5. If you have a positive result, about 1 in 5, that the pregnancy or the surviving twin is affected by trisomy 21. If it's trisomy 18, it's 25%, 1 in 4, and for trisomy 13, it's difficult. It's difficult really to look at the literature because the numbers are very, very small. He also mentioned the fact that this is less likely to be the case, or the false positive rate is lower in type 1 vanishing twin when you don't have an embryo in the gestational sac, compared with type 2 when you have an embryo or non-viable embryo in the gestational sac. And again, the risk is lower if you have the NIPT later in pregnancy after 14 weeks. And he showed you that in an NHS in the UK, because the NIPT is not reliable in the vanishing twin, the combined test is also not reliable. And therefore, we should not be offering the NIPT in these cases. And in the American College guideline, the fact that the NIPT is not reliable, combined test is not reliable, and therefore we should consider offering diagnostic test. This was a case again of vanishing twin, really complex case. I'm going to skip because of the time, because we're so late. And also the co-twin demise. I think we, Mark and Francesco showed us the fact that we could repeat the sample, and the fact that there is cell-free DNA from the demise twin that persists in the maternal circulation until 8 weeks. But certainly there's some data suggest that maybe up to 15 weeks that there is still some DNA from the vanishing twin in the maternal circulation. Finally, about triplet pregnancy, and this is again data that we looked at recently about the performance of cell-free DNA in triplet pregnancies. So 1,000 triplet pregnancy, the failure rate was 2.4%. And for trisomy 21, the data appears very promising. Detection rate of almost 100%, specificity 99.5%. So appears promising. But of course, we need more data. For trisomy 18 and 13, it's difficult to really comment on the diagnostic accuracy. But that means when we have a triplet pregnancy and you counsel them about the option of selective reduction, at the moment you see the patient at 10 weeks, you do ultrasound scan, you counsel them about the option of selective reduction. There are some centers that offer CVS of the 3 babies, the 3 fetuses, before they offer the option of selective reduction, because the CVS help them to guide which triplet to reduce, or confirming or trying to rule out major genetic abnormalities. But the fact that we have the option of NIPT, that means we could actually do the counseling at 10 weeks, do the ultrasound scan, and do the NIPT at 10 weeks. And if it's low risk result, means there's no need to do the CVS. And that means we could actually offer the option of selective reduction at 12 weeks after doing an ultrasound scan for the nuchal translucency and ruling out major abnormalities. So really the key home message is NIPT in twins promising, but likely have lower accuracies than for trisomy 18 and 13. I think it's similar performance. You can offer it in dichorionic as well as monochorionic twins. The NIPT is important. It does not give us individual fetus risk estimation. And therefore is for us as a clinician to try to work out which twin is affected, because most of the cases when there is a trisomy 21 and twin pregnancies often affect one twin. It's rare to have both twins are affected, particularly in a dichorionic twin pregnancy. NIPT in vanishing twin, we have higher false positive rate, but the false positive rate tend to be lower if the vanishing twin has an empty sac, there's no embryo inside, and if the sample is taken after 14 weeks